Today we will be talking about the left posterior fascicular block. We have already covered the left anterior fascicular block. The cardiac conduction system, when it enters into the ventricle at the of lower than the bundle of His, it has three branches. One is a very small septal branch, and one branch goes towards the right ventricle, which we call the right bundle branch, and another branch goes towards the left ventricle, which we call the left bundle branch. That left bundle branch then subdivides into two fascicles. One is the left anterior fascicle, one is the left posterior fascicle. We have already covered the left anterior fascicular block, and today we will be having a little talk about the left posterior fascicular block. Now, if we look at this diagram, it's a very famous diagram of the cardiac conduction system, where we see SA node, Batchman tracts, AV node, bundle of His, right bundle branch, and left bundle branch. Then we see that the left bundle branch is actually dividing into anterior fascicle and the left posterior fascicle. Here we see that the topic we are going to talk about today is the blockage at the level of the left posterior fascicle. So left posterior fascicular block is at this level, and we will see what changes it causes in the ECG once a patient has this blockage in the left posterior fascicle. So whenever a patient presents with the left posterior fascicular block, there are certain diagnostic changes in the ECG, which you are to pick up and actually make a decision about the left posterior fascicular block. One is that there is a right axis deviation where lead 1 is negatively deflected and AVF is positively deflected, and this axis falls somewhere between positive 90 to positive 180 degree. That is the right axis deviation. The second thing, the diagnostic change which you will see in the ECG is in the lateral leads. 1 and AVL are the two lateral leads. There would be a small Q and deep S wave pattern. You will see a very small R wave or a positive deflection and a very deep negative deflection or S wave. So the QS pattern in lead 1 and AVL, which are the lateral leads. Then another change which you see in the ECG of left posterior fascicular block is QR pattern in the lead 2, 3 and AVF, which are the inferior leads. QR pattern means there would be a very small R wave and a tall R, very small Q wave and a tall R wave in the 2, 3 and AVF or the inferior leads. They are the positively deflected leads. So in cases of the left posterior fascicular block, there would be a right axis deviation, there would be a very small R wave and a deep S wave in lead 1 and AVL, and there would be a small Q wave and a tall R wave in lead 2, 3 and AVF. And QRS complex would be narrow. It would be less than 0.12 second in duration. Now, if you look at the ECG of a patient who's having left posterior fascicular block, we see the diagnostic features in the ECG are lead 1 is negatively deflected while lead AVF is positively deflected. So this is a right axis deviation. And the second change which you see in a case of the left posterior fascicular block is the lateral leads 1 and AVL. If you look at lead 1 and AVL, there is a small R wave or a small positive deflection and a deep S wave. So this is a R S pattern in lead 1 and AVL. The third criteria of the left posterior fascicular block is that the inferior leads, which are 2, 3 and AVF, they have got a very small Q wave and a very tall R wave. So 2, 3 and AVF, they have got small Q and large R wave pattern. So, and the last criteria, the fourth one, is that there would be a narrow QRS complex. It would be less than 0.12 second in duration, or it would be less than 3 small boxes. So in order to just recap the diagnostic feature in the ECG, we see there is a right axis deviation which lies somewhere between the 90 and plus 180 degree, and lead 1 is negative and AVF is positive. And the second criteria is that both the lateral leads, which are 1 and AVL, they have got a very small R wave and a very deep S wave. And lead 2, 3 and AVF, which are inferior leads, they have got a very small Q wave and a large or tall R wave. And the last criteria is that it has got a narrow QRS complex, which is less than 0.12 second in duration. And what are the causes of the left posterior fascicular block? The most important cause would be the ischemic heart disease. There can be pulmonary hypertension. There can be right ventricular hypertrophy. So now we have covered the bundle branch blocks in total. So there is always a level of difficulty when you are to make the difference which type of the block patient is suffering. The first and foremost thing would be the QRS duration. If the QRS duration is more than 0.12 second, then the bundle branch block would be either right bundle branch or the left bundle branch block. And then you are to see lead V1 and V5 or V6. If there is RSR pattern in lead V1 or V2, it's surely the right bundle branch block. And if you see M pattern in V5 or V6 with the broad QRS complexes, it would surely be the left bundle branch block. But say if you see a broad QRS complex and you do not find a difference between any specific characteristics of the V1 or V2, then you are to consider only the V1. If there is a deep S wave in the lead V1, it would be left bundle branch block. But if you see a broad QRS complexes in all of the ECG leads and there is a tall R wave in the lead V1, then it means the patient has got a right bundle branch block. But in cases of the fascicular blocks, the QRS complexes would be narrow in both the left anterior and the left posterior fascicular block. But in cases of the left anterior fascicular block, because anterior is ahead of everything and we so much hear about the left axis deviation. So there would be a left axis deviation associated with the left anterior fascicular block, and we know that in left axis deviation there is a positive deflection in lead 1 and a negative deflection in lead AVF. So when we see that there is a positively deflected 1 and AVL and negatively deflected 2, 3 and AVF and narrow QRS complex, then for sure we know this is left anterior fascicular block. But in cases of the left posterior fascicular block, there should be a right axis deviation, and in right axis deviation 1 is negative and AVF is positive. That means in cases of the left posterior fascicular block, we will see -1 and AVL. When I say negative, it means a very small R wave and a deep S wave, so RS pattern. And in case of the left posterior fascicular block, the inferior leads 2, 3 and AVF, they would be positively deflected. And when I say positively deflected, it means it would be a very small R wave and a very small Q wave and a tall R wave. So that would be a QR pattern. So in a way, this will help you understand the difference between the right bundle branch block and the left bundle branch block, and their sort of differentiation from the fascicular blocks. So knowing the QRS duration, knowing the association of the right and the left axis deviation with the anterior and posterior fascicular blocks, and that would help you better understand the concept of the fascicular block and the main branch block.